Good afternoon and welcome to the monthly Care Partner training at Insight Memory Care Center. Our mission is to provide specialized care, support, and education for individuals in all stages of memory or cognitive impairment, their care partners, and the community. Our vision is a community where those living with memory or cognitive impairment and their care partners can achieve the highest quality of life. Today, we're going to be talking about dementia, depression, and delirium. And now I'd like to introduce Vivek Sinha. He's a family medicine board certified American Board of Family Medicine Diplomate. He is the chief medical officer of Belleview Medical Partners, a primary care practice based in Alexandria. His practice is a combination of traditional office-based primary care medicine and concierge services. He has a house call component that incorporates multiple modalities, including hospice and palliative care services. He originally hails from Long Island, New York, where he worked as a firefighter and emergency medical technician before following in his father's footsteps to become a family medicine physician. Dr. Sinha completed his residency at the Northwestern Affiliated Family Medicine Residency Program at St. Joseph Hospital in Chicago, Illinois. After serving as chief resident, he joined the teaching facility where in 2008, he received the Family Medicine Teaching Award. Dr. Sinha serves as the medical director for the Alexandria Silverado Memory Care Community, a nationally recognized organization serving those with Alzheimer's, dementia, and other associated impairment conditions, as well as the Providence Fairfax Senior Living Community. As an extremely active member of his community, he serves as a board member for the Senior Services of Alexandria, as well as contributing columnist on medical topics to the Alexandria Times newspaper. Dr. Sinha is also the medical director for the Alexandria City Public School System and Fairfax County Public School System. Dr. Sinha is one of the lead physicians on the National Medical Response Team, a federal asset team responsible for decontaminating and treating members of the government during the presidential State of the Union addresses, where he was tasked with providing force protection for his team members and other federal partners. He is also an active medical officer for Maryland's Federal Disaster Medical Assistance Team. His missions on his various deployments have ranged from hospital decompression missions in hurricane-ravaged locales to providing care at mass gatherings in the heart of DC. His in-field experience incorporates several presidential inaugurations, several national security events, and multiple hurricanes, including Hurricane Sandy, Harvey, and Michael. Now, without further ado, let's welcome Dr. Sinha.
Vivek Sinha. I'm a family medicine physician, and I'm happy to be here. I'd like to start off by asking a few questions. So, why is it that you rarely see EMS personnel running to see a patient? I'm sure we've all seen an ambulance pull up. I'm sure we've all seen the medics get out. And I'm sure we've all seen them walking purposefully, riskfully to the patient. But why is it that we never see them running? Why is it that airlines ask us to put our oxygen masks on first before we help our family members? Why is that? And then why is it when we teach CPR to medical students and to resident physicians in training, we always ask them, when you're called to the scene of a cardiac arrest, what's the first thing you check? 100% of the time, the answer is they check the patient's pulse. And 100% of the time, that answer is wrong. The correct answer is you check your own pulse first. Why is that? So emergency personnel, airline personnel, hospital personnel, they all know that unless you take care of yourself, you will go from being a caregiver to a patient. It's the reason why EMS doesn't run to the scene, because they can fall, they can get hurt. It's the reason why airlines ask us to put our oxygen masks on first. It's the reason why trained hospital personnel take a breath before they jump in to care for somebody. This concept is critically important for anyone who's in a position where others rely on them. In some way, shape, or form, everyone in this room is a caregiver. Everyone at home is a caregiver. Spouse, parent, sibling, friend, neighbor. there is someone who depends on each of us here. And unless we approach caregiving the same way as our EMS people, our hospital people, or our airline people, we have the potential to become a patient rather than a caregiver. We can only help others if we're physically and mentally able to do so. So I always like starting off my talks by talking about that. Thank you for being here. So today we're going to talk about 3 Ds, but we're going to use the mnemonic of 5 Ds. We're going to talk about dementia. We're going to talk about depression. We're going to talk about delirium. And then each of these conditions we're going to define. We're going to diagnose, figure out how physicians diagnose these conditions, and then what is the big difference between these conditions? Let's jump right in. What is dementia? From the Alzheimer's Association, a general term, dementia is a general term for a decline in mental ability severe enough to interfere with daily life. It's not a specific disease. It's actually a wide range of symptoms. And it's really critically important for us to correctly identify the specific type of dementia that a person may have, because the treatment may vary. So the different types of dementia, by far, the most common type of dementia in this country is Alzheimer's dementia. It constitutes 60 to 80% of cases. Typically, it presents at the age of 65. However, early onset dementia can present earlier, as early as age 40. Memory impairment is the most common primary complaint. Vascular dementia is the second most common type of dementia. Its underlying cause is vessel damage causing blood flow issues to the brain. So uncontrolled hypertension, strokes, things like this can lead to vascular dementia. Dementia with Lewy bodies is the third most common cause of dementia. Lewy bodies are actually collections of protein that deposit in certain portions of the brain. And you can have problems with attention and visuospatial functioning, such as difficulty driving or misjudging distances. Visual hallucinations can also occur. Very similar in appearance to Parkinson's dementia. The frontotemporal dementia is a type of dementia where the front part of the brain, the frontal lobe, and the sides of the brain, or the temporal lobes, are affected. And patients will typically present with apathy, less interest in themselves and their surroundings. They'll have compulsive behaviors. And then the last one that we'll mention here is Parkinson's disease with dementia. Now, Parkinson's disease is actually a movement disorder. It manifests in patients having a resting tremor, difficulty in movement, limb rigidity, and then eventually we can have declining cognitive function and visual hallucinations. So even though we talked about these 5 different types of dementia, it's obvious that there's a lot of overlap between these types of dementia. And it can make the specific diagnosis of the specific type of dementia a little difficult. And sometimes we can have more than one type of dementia involved. So memory impairment, decline in executive functions, and change in behavior symptoms are the hallmarks that we see. So how do we diagnose? So as a primary care physician, one of the most common questions is, can you test my mom, my dad, my loved one for dementia? So the diagnosis is tricky. It's important to diagnose correctly. It presents very slowly over time. And there is no specific blood test that 100% accurately rules in or rules out dementia. So like most medical conditions, I feel that to start off with an accurate diagnosis, the most important step is an accurate history. Talking to the patient, talking to the family members. And I divide my history taking into 2 main sections.
We have a question that popped up. Someone didn't quite hear the description of frontal temporal lobe dementia. So could you please repeat the 2 characteristics of frontal temporal that you had said?
Sure. So frontotemporal dementia is where you see the damage occur primarily in the frontal part of the brain and the temporal part of the brain, or the sides of the brain. Now, those specific portions of the brain are responsible for certain functions, and that's the difficulty that we see. So we see patients with frontotemporal dementia have a prominent change in social behavior and personality, and they can have compulsive behaviors and disinhibition. So I divide my history taking into two main parts. First is age of onset, and second is cardinal signs and symptoms. So let's talk about age of onset. So typically, age of onset is that dementia presents usually when the patient is greater than 65 years of age. The incidence of dementia actually increases as we age. So every 5 years, the prevalence of dementia can double. However, the age of onset is not 100%. There is early onset dementia that can occur before the age of 65. It's not as common, but it absolutely can occur. We see this in patients in their 40s and their 60s. So patients who have early onset dementia may present with symptoms of difficulty at work, difficulty with relationships. Those are the things that we see when a patient who's younger than 65 comes to us. So let's talk about some of the cardinal signs and symptoms that we see with dementia. And it's divided into three main parts: memory impairment, executive function, and behavioral and psychological symptoms. Right. So let's start with the first one, memory impairment. Specifically, it is episodic memory impairment. Now, what that means is these are memories of events occurring at a particular time and place. The memory depends on certain portions of the brain. The two specific portions are the hippocampus, which is that top picture, and the temporal lobe, which is the bottom picture. These are the structures that are primarily affected early on in dementia. Now, episodic memory is divided into three different types or three parts. The first one is immediate, and immediate recall. That is, what room did I just walk into? I'm in the bathroom, I'm in the family room. That's immediate memory, immediate recall. Second one is recent event memory. This is memory that needs to be remembered. What is my home address? What is my phone number? That's what recent memory is. And then there's distant memory. Where did I grow up? What is my mother's name? Where am I from originally? That's distant memory. Now, recent memory, that middle one, is the one that is most commonly affected first with dementia. It's also known as short-term memory. So patients may remember where they grew up. They may remember their mother and their father's name, but they may not remember where they live. They may have difficulty remembering grandchildren's name and so forth. Now, this progresses very slowly over time, and that's what makes it difficult. Oftentimes, a child or a spouse will bring the patient into the office and say that their loved one is becoming more forgetful, more irritable, more easily distracted. It's difficult to state exactly when these symptoms start. Then we talk about decline in executive function. So what is executive function? Executive function is our judgment. It's our problem-solving ability. It's our planning. It's our inhibition control. And the early stages of these symptoms may be very, very subtle. You may find that people are becoming less organized. They're less motivated. It's difficult to multitask. And eventually this leads to an inability to completing difficult tasks, difficulty in word finding, getting lost in familiar places. It's also common for patients to have reduced insight into how severe their problems may be, which stresses the importance of having an advocate for all of our family members, having family members, having loved ones that look out for one another. And then the third one is behavioral and psychological symptoms. So this can begin very subtly. Most of these symptoms are very subtle, and that is really important to remember when we talk about dementia versus delirium in the future. So patients can present with apathy, with lack of interest, with mild irritability that continues on, with social disengagement. They're not as social as they used to be. They don't want to go out. They don't want to see friends. It's also very important to screen for depression at this point, because depression can also present with symptoms that are very, very similar. Now, of course, we'll talk a little bit more about depression in just a minute, but it's also important if a patient who ultimately is determined to have dementia, initially they may actually present with agitation and aggression and psychosis. And if that's the case, it's really important to differentiate that from delirium, which we'll also talk about in just a few minutes. So after I've talked about this, we then I like to do what's called some sort of cognitive exam. Now, the most common cognitive exam that's used is the mini mental state exam. Now, it can be administered. It's a series of questions and tasks that we ask the patient to do. It is very brief. It can be done in about 7 to 10 minutes. There's scoring for each level, and a maximum score is 30. If it's below 24, that usually means there's some level of cognitive impairment. So some of the questions that we ask in the mini mental state exam are, what is the date? Where are we right now? What building is this? Name 3 objects. The patient has to remember the 3 objects, and then later on in the exam, we ask them to recall the 3 objects. We do some difficult math problems, meaning we do what's called serial sevens. We start at 100 and have the patient subtract 7 to see how far they can go. We have them spell the word world backwards without writing it down. We point to several objects and we have the patient identify them to see if they know what they are. We have them repeat phrases that may be very difficult to do for somebody with cognitive impairment. The phrase that we use is no ifs, ands, or buts. And a person with moderate cognitive impairment will have a difficult time repeating that sentence. We have them follow 3-stage commands where we'll say 3 commands at one time and then see if they can do each one sequentially. Then we'll write something down and we'll have them follow written instruction. And then of course, we'll have them write a sentence and copy a design as well. Now, this is just a good overall screening tool. It's not the end all be all, but it's a screening tool that physicians, primary care physicians, frontline physicians like to use to see if we need to investigate further. So after this, the next step is examination and lab work. So a very thorough examination is important. We check the patient's vital signs, we check their heart, their lung exam, we do a full neurologic examination, and then we do lab work. We check labs that, if they're abnormal, they may mimic signs and symptoms of dementia. So patients with thyroid problems that are undiagnosed may actually have symptoms that are similar to dementia. We check for certain vitamin deficiencies that can present with symptoms like dementia. We check for infections, metabolic problems. We check urinalysis to make sure there's not an infection. And then occasionally we'll do other labs like HIV lab work and syphilis. And we'll do lumbar punctures if we're worried about something that's presenting very quickly. We also can check blood metal levels, copper and lead. All of these can affect patients' memories and can present with symptoms like dementia. And then, of course, we consider imaging. Now, imaging is not done right away. CAT scans of the brains, MRIs of the brains, some with, some without contrast, they are useful. They're very, very useful to make sure that we're not missing any other diagnoses, make sure that we're not missing any bleeding in the brain, making sure we're not missing a big tumor like this right here, like this tumor is right there, making sure that there's not excessive fluid in the brain. These are all things that can be treated and they can present with symptoms like dementia. Most patients that we end up diagnosing with dementia end up having essentially normal CAT scans and normal MRIs. But there are some subtle findings that we do see. In patients with frontotemporal dementia, we'll see shrinking in the frontal and the temporal parts of the brain. In patients with Alzheimer's dementia or Lewy body dementia, we'll see a general atrophy or just a general shrinking of the brain in general. In vascular dementia, we'll see what's called white matter lesions, which have to do with the blood vessels, which can be caused by uncontrolled hypertension, high blood pressure, and uncontrolled or strokes that the patients may have had. So once we diagnose somebody with dementia as a primary care physician, the next step is we have to have a team approach. We often can start medications. We absolutely do refer off to neurologists, to neuropsychologists, to geriatric psychiatrists, to geriatricians. So ultimately, it is a team approach, and that's how we approach it. Now, in this context, we won't go into the very specific medications and the treatment for dementia. But is there any questions online or anybody here that has any questions on dementia before we move on to the next? Okay. So let's talk a little bit about depression. Now, if you'll remember, some of the symptoms of early on symptoms of dementia can actually present like depression. And it's important to know that patients with dementia can absolutely have depression as well. So it's important to know exactly what we're treating. So according to the World Health Organization, over 300 million people worldwide suffer from dementia. In the developed countries, it's as high as 18%. Typically speaking, sorry, I said dementia, but I meant depression. Typically speaking, depression is diagnosed usually younger in age. The average age of diagnosis for patients with depression is 30. Now, obviously, it can be higher, it can be lower. And prevalence for depression typically decreases, except in one very important circumstance. It can increase in older patients who have chronic medical conditions, who live in assisted living facilities, who live in nursing facilities, or who require home health care. So in patients who require those services, it's often common to see depression as well. So depression is essentially a description of your mood state. Patients with depression will often describe themselves as feeling very sad, as having, feelings of despair, feelings of apathy, feelings of emptiness and hopelessness. It's important to know that these feelings actually may be a normal response to certain situations, life changes, deaths in the family, perceived failures in job or relationship. These sort of things can cause depressive symptoms. That doesn't mean that the person has depression. There's very different types of depression as well. And in the workup, it's important to diagnose these because sometimes they're treated a little differently. There's major depressive disorder, there's minor depression, there's something called dysthymia, there's bipolar depression, which is a very specific type of depression. There's substance-induced depression. So it's important during the workup for the physician or the provider to know exactly what sort of depression the person may have. Now, the signs and symptoms, they may be very, very subtle. They're feelings of overwhelm. Patients can present complaining that they're constantly worried. They can't go to sleep at night because their mind is just completely active. They're very, very fatigued. They may be getting too much sleep or not enough sleep at all. They may have a decreased appetite where they're losing weight or an increased appetite where they're gaining weight. They can have a very short fuse, easily irritated, angry. It's a very common phenomenon to see pain manifestations of depression, chronic headaches, chronic back pain, very, very common in patients who suffer from depression. And also we can see patients trying to self-treat with excessive alcohol. So there are certain risk factors for depression. Depression can affect anybody, but there's certain patients that we actually specifically look for depression because we know the chances of them having depression are higher. One of the most common ones are caregivers, people who care for others. In fact, caregivers, people who are caring for somebody with dementia, those caregivers are 50% more likely to suffer from depression. We know that there is a sex difference, men versus women. We know that women statistically have a higher rate of depression than men. However, women go to the doctor more than men. So men are more likely to hide their symptoms, more likely to not admit their depressive symptoms, and more likely to self-treat. We know that if somebody has a family history of somebody with depression, that can make your risk factors for depression higher. We know that there's certain socioeconomic factors, lower income, poor social support, childhood trauma, all of these things can increase your risk for having depression. And then we know that there's other medical conditions that can lead to depression. The biggest medical condition that can lead to depression is dementia. So patients who have a diagnosis of dementia can actually develop depression afterwards, and that can make their symptoms of depression appear to worsen. So it's very important for the family and the provider to constantly be screening for depression with these patients. So there's a screening tool, just like we have the mini mental state exam that we use in the office. There's another screening tool that we use, super quick, for screening of depression. And it's a mnemonic. It's called SIG-E-CAPS. So we ask the patient these very specific questions. We ask, are they having any sleep changes, any decreased sleep or early morning awakenings? That's the S. The I stands for any lack or loss of interest in things that they're normally interested in. The G stands for any feelings of guilt, feelings of worthlessness. The E stands for decreased energy. The C stands for decreased concentration. Are you having a hard time concentrating in your relationships? Hard time concentrating at work? The A stands for a change in appetite. Is it significantly decreased or significantly increased? The P stands for psychomotor activity. Is it difficult to move? You just stay in bed all day. And then the S stands for any suicidal or self-harm thoughts. So the patient has 5 or more positive responses. If they say yes to 5 or more of these, and if it's been present for more than 2 weeks, then that is a positive screening test. And we need to have a focused discussion about depression. Now, I've diagnosed patients with depression who just have 2 of these or 3 of these. So 5 is a rough guideline. But what do we do if we think somebody has depression, if they answered positively to these screening questions? Well, then we do the same thing. We start with a very thorough history. We check with them. What are the extent of their symptoms? What is the effect on your lifestyle? That's very important. Is it affecting your day-to-day? Is it affecting your job? Is it affecting your relationships? We ask them about their medical history, their drug and alcohol history, family history, social history. So a detailed history is very, very important. And then the next step would be a physical exam. Again, heart exam, lung exam, vital signs, a neurologic exam. If I am screening somebody or diagnosing somebody with depression, I will always do a mini mental status exam. To make sure that it's not cognitive impairment that we're actually seeing as opposed to depression. And then, of course, we would do some blood work. We do these studies to look for conditions that can mimic depression, but it would be caused by something else. So things like kidney or liver dysfunction, low blood count, like anemia, can make you very, very fatigued and tired. Thyroid problems, underactive thyroid, overactive thyroid, testosterone problems in men, vitamin levels that can be low, and then any additional lab work that we think the patient may need, we would do. We may do some imaging studies. In some circumstances, we may do a CAT scan or an MRI of the head. But again, we do these studies to rule out other conditions, to make sure we're not missing anything else. So in order to formally diagnose somebody with depression, there is 4 criteria that we use, that psychiatrists use, that primary care providers use, in order to formally give somebody a diagnosis of depression. The first criteria is the patient must have 5 or more of the following for a period of time, usually more than 2 weeks. depressed mood, decreased interest, unintentional weight loss, sleep changes, feeling of worthlessness, decreased concentration, and recurrent thoughts of death. So 5 or more of these. The second one is their symptoms must be causing some sort of effect in their life. It must be causing difficulties in their social setting, in their personal relationships, in their work relationships. And then number 3 and 4, these symptoms are not attributable to anything else. So all the lab work was negative. And number 4, the patient has never had any manic episodes. If they've had manic episodes, then we worry about a condition called bipolar disorder. And there's different types of bipolar disorder. Sometimes patients with bipolar disorder can present just like depression. And when we treat them for depression, they can go into a manic state. So it's very important to make sure that they have that 4th criteria. They've never had any manic episodes. So once somebody does get diagnosed with depression, what's the next step? Well, the next step is talk to your provider, talk to your physician. If it's your loved one, bring them to the doctor. There's 2 main categories of treatment. There's talk therapy or psychotherapy, and then there's medication management. Sometimes we just start with psychotherapy. Sometimes we start with medications first before they even get to psychotherapy. So a team approach is needed. Primary care physicians, psychologists, psychiatrists, licensed clinical social workers, neurologists, the team approach is needed. Now, before we talk about delirium, I do want to talk about dementia and depression. In older patients, if they are presenting very subtly, it's possible that they actually have depression and not dementia. It's so common that there's a term for that. It's called pseudo dementia. And if you treat their depression symptoms, their symptoms of what we think is dementia may actually get better. But very rarely in the real world is it that clear cut. Oftentimes, patients will have a little bit of both at diagnosis. So oftentimes, if we are diagnosing somebody with dementia, we will also treat them for depression, and we follow them to see how they're doing. So before I talk about the last topic with delirium, is there any questions that we have? Yes.
Did you say that you look for if they've had a manic episode and then they're medicated?
So the question is, if somebody has had a manic episode and then they're medicated. So when we're diagnosing depression, somebody may have bipolar disorder. And when they have bipolar, they can have symptoms of depression for a period of time. And then they can go into a period of mania or have a manic episode. Now that's very dangerous because the risk of suicide is very, very high during a manic episode. And sometimes if we don't properly screen somebody, if we treat them with particular medications for depression, that can actually push them into a manic episode. So if anybody has ever prescribed a medication for depression, one of the things their provider should tell them is if you're having any of the signs of that mania, which we would talk about at length, they would need to call right away. So that's why we always follow up with patients quite regularly when we start them on any medication, especially an antidepressant medication.
If they've never had one of those episodes and they were put on that sort of medication, could they then have an episode like that?
So the question is, if they never had a manic episode and they were put on an antidepressant medication, could they go into a manic episode? And the answer is yes, if they actually have bipolar disorder. So if somebody's had a manic episode, we would be very careful about the type of medicine we would start them with. If they've never had a manic episode and they have bipolar, but we don't know it yet, the way that we work that is we start them on a medicine, but we still follow up with them very closely. So it's not a type of medicine that you get prescribed once and you follow up in 6 months. You follow up very regularly. Okay. So the last part that we'll talk about is delirium. Now, delirium can occur to anybody regardless of your age. When I was in residency and we wouldn't sleep for about 40 maybe about 36 hours, we would go without sleeping, maybe a little longer. I would have symptoms of delirium. My driving time would be diminished. My reaction time would be diminished. If I were to get a fever of 104, 105, I would become very delirious. So delirium can occur with anybody at any age.
So we had a question pop up. Does Lewy body present with manic episodes ever?
So manic episodes, the question is, does Lewy body present with manic episodes? So it can, under a few different circumstances. You can have somebody who has bipolar disorder end up getting Lewy body dementia. So it can present like that. We've had patients who likely have had bipolar, but have never really been diagnosed. And when you have any sort of dementia, it can exacerbate all of your other conditions. But typically speaking, in Lewy body dementia, there can be psychosis, and there can be auditory and visual hallucinations. And some of those hallucinations and psychosis can present very similarly to somebody having a manic episode. So the bottom line is, a lot of these symptoms it's an evolution. And what somebody is diagnosed with initially, their diagnosis may evolve as they get treated, as time goes on.
Thank you.
So delirium it's among the most common mental condition encountered in patients who have any sort of medical condition. So it can affect you at any age. It's primarily been studied in hospitals. And when patients are hospitalized, especially patients with dementia, when they are hospitalized, it is very, very common for them to have delirium as well. Nearly 30% of older patients who are hospitalized will have some level of delirium, either immediately after or during their hospital stay. Older patients who have specific surgeries, cardiovascular surgeries, or hip surgeries, for some reason are at higher risk of having delirium as well. So what is delirium? So the American Psychiatric Association Diagnostic and Statistical Manual, which is the 5th edition, in other words, we call it the DSM-5, has specific criteria to say what delirium is. So number one, there has to be a disturbance in attention and awareness. The easiest way to describe that is there has to be an increased amount of confusion. So it has to be a higher level of confusion than what the patient normally has. There has to be some sort of change from baseline. You have a patient with dementia who normally doesn't know their address and doesn't know their medications, and they're hospitalized, and they're asked where do they live, or they're asked about their medications and they don't know, that would not be a criteria for delirium because that is their baseline. There has to be a quick change. Dementia occurs relatively slowly. Delirium occurs very, very quickly. It can occur within hours to days. So a rapid change makes us worry about delirium. There has to be, in a patient who does have memory issues, there has to be an additional memory issue that is new. So if somebody is normally disoriented, but they can speak properly, and then they go to the hospital and they continue to be disoriented, but now they can't speak properly, that would be a criteria for delirium. And their symptoms should not be better explained by their pre-existing conditions. For instance, we have to determine, is this a natural progression of their dementia, or is this a delirium? And oftentimes, we need to have a reason as to why they are having a delirium. So for instance, when patients are in the hospital and they're doing fine, they have dementia, they're doing fine, they're getting treatment, then all of a sudden they get more confused. We do a very specific workup, which includes a lot of blood work, imaging, sometimes a lumbar puncture, and we're checking for very specific things or worsening medical conditions that can cause them to become delirious. Now, there's risk factors for delirium. So any patient who has dementia is at very, very high risk for having delirium as well. Patients who have had strokes, patients with hip fractures, like we talked about before, any patient who has sensory impairment, if they're hard of hearing, if they can't see properly, anybody with advanced age, can get these conditions that can cause delirium. Those conditions that can cause delirium are infection, dehydration, malnutrition, medications. Oftentimes, doctors are the ones that can cause delirium by giving too high doses of medications or the wrong type of medication. Constipation is a big one for causing delirium. I go to several memory care communities, and when patients who have dementia, when there's a sudden change, one of my first questions for that nurse is, when was their last bowel movement? So constipation can absolutely lead to delirium. And of course, pain can definitely lead to delirium as well. So typically patients with delirium, as we talked about before, will present with a disturbance of consciousness. It may be subtle at first, but it should be relatively quick onset. And then there's a change in cognition. So there's some sort of new auditory or visual change. It's an inability to write, speak. It should start within hours to days, and it can last for days to weeks to months. But the important thing is delirium can be reversible. If we treat the underlying cause, oftentimes delirium will significantly improve, and oftentimes it will completely resolve, and the patient will go back to their regular baseline. These features for delirium are usually worse at night. There's conditions, one of them is called sundowning. When the sun comes down, symptoms are worse in the evening and at night. And then, of course, there's other features as well. Irritability, their sleep-wake cycle can reverse. Patients can become extremely anxious. They can become quiet or withdrawn. And that's important. In patients who have dementia, sometimes if they become quiet and withdrawn, we become very concerned because there may actually be something else going on and they're just not able to express what's happening. So the big question, since this can occur in the light of dementia, is how do we tell the difference? By far, the most important thing is we need to know the patient's baseline level. All the more important why we need to have continuity of care. If a patient from a nursing home or a memory care community who has dementia gets admitted to the hospital, it's very important that there be an advocate for that patient in the hospital. Somebody there, whether it be a family member or a care manager, somebody who is there to help that patient and let the staff at the hospital know this is their baseline, this is not their baseline. We look for clues for causes. We check for, has the patient had a seizure? I had a patient last week at one of my memory care communities where all we saw was in the morning was she had a bloody tongue. And so when we observed her, when we did an exam, turned out she was having acute delirium. She had had a seizure. And during that seizure, she bit her tongue. So we checked for blood in the mouth. We checked for shoulder dislocation. Shoulder dislocation can occur if somebody is having a grand mal seizure that's unwitnessed and their bones are weak and they dislocate their shoulder. So checking for signs of seizures, checking for muscle jerking, for new tremors, checking for signs of stroke or infection, fever, facial paralysis. These are all things that we need to do when somebody presents with symptoms that are suddenly worse. So one of the things when I used to teach medical students and residents, I would say, what should you ask? And I would tell my patients' families, make sure the doctors ask this question. So the provider or the doctor should ask, what exactly is different? How was the patient yesterday compared to today? Is there anything different in the environment? Has the patient moved from the home to a hospital? That can lead to delirium. Are they on any new medication? That is a big one. Any onset of new medications, regardless of what it is, can lead to symptoms that can be consistent with delirium. We need to make sure that the doctors are checking their vital signs. Are their blood pressure excessively low? Is their heart rate excessively high? Is there a high fever? All of these things can lead to delirium. Is there a decrease in oxygen level? Hypoxia is not enough oxygen to the brain. That can lead to symptoms of delirium. Blood sugar, low blood sugar. Patients who are sometimes transferred from nursing homes to hospitals, sometimes their medications aren't exactly transferred over as they should be. And oftentimes patients who are diabetic may get too much diabetes medicines in the hospital or too little. So checking the blood sugars are important. Making sure their last bowel movement was appropriate and they're not having excessive constipation. And then making sure that they don't have any other symptoms of urinary infection or any pain. These are things that the doctor should ask. So how do we treat acute delirium? Well, the best treatment is prevention. So hospitals are aware that delirium can occur in all patients, especially in patients who have dementia. So orientation protocols are very important. These can be initiated in the home. Having clocks that very clearly state the time, that state the date, that state morning or afternoon can be very helpful to help orient someone. Having cognitive stimulation, having friends come visit the person in the hospital, people that they're used to seeing. If there's a caregiver at home, then having that caregiver come to the hospital, if possible, is also important. But you want to avoid overstimulation, especially in the evening times. Protecting their sleep. This is something we battle with all the time in the hospital. We really want doctors and nurses to realize that sleep is very important. Is it important to check that blood pressure at 3 in the morning? Well, sometimes it is. And if it is, we should do it. But sometimes it's not as important and it can wait until 6 or 7 a.m. Is it important to give a medicine that's given 6 times a day when 3 or 4 times a day will work? Sometimes it is, sometimes it isn't. But at least these are things that should be asked. Protecting the sleep is critically important. Early mobilization, getting the patient, especially if they have dementia and they're in the hospital, getting them to sit up in bed, getting them to sit up in the chair. If they can't walk, having them sit in the chair when they eat. So it's at least 2 to 3 times a day. Utilizing physical therapy, occupational therapy, right away after surgery is very, very important. Making sure that if somebody has any sensory impairment, if they have hearing aids, if they have glasses, making sure they have them. Because if they're used to that, they no longer have that, and they're in a new environment, that can lead to acute delirium. And then addressing pain. Oftentimes, patients with dementia cannot tell us that they are in pain. So a lot of times doctors will write pain medication to be given every few hours as needed. The problem is the patient can't express that pain. So close monitoring is very important. Considering scheduling non-narcotic pain medications, Tylenol every 4 to 6 hours, or every 6 hours for the next 3 days. Things like that can be done. The other treatments, and this is the last slide, but the other treatments are treat the underlying condition. If they're dehydrated, give them IV fluid. If their sugars are low, give them something to raise their sugars up. Give them antibiotics if we think they have an infection. Try to find the source of infection. Check for drug toxicity. Any new medications that have started that may be interacting with their current medications. Alcohol withdrawal is a big one. Patients who have chronic alcohol use, if at a certain level, if they suddenly stop drinking alcohol, they can become very, very agitated about day 3 or day 4 into their hospitalization. We see this all the time. Patients who are self-medicating with alcohol or drinking alcohol are fine day 1, day 2, day 3 in the hospital, and then day 4, there's sudden confusion. So these are things that we look for. Bottom line is delirium can occur at any time. A scenario that I often see is that a patient will tell me, my mom did not have dementia until she had a urinary tract infection. And what's actually happening there is she actually had mild dementia, but that patient was masking it, was compensating for those symptoms. Then she got a second hit. She got a urinary tract infection and was hospitalized. She then ended up going into delirium, and she could no longer mask her symptoms of dementia. So that's often a scenario that we see. So dementia, delirium, depression can be separate. They can definitely be hand in hand. So that's all the slides that I have. And, I'm happy to answer as many questions as anybody may have.
Dr. Sinha, do you have any tricks? We know obviously dehydration is really common with older adults. You have some tricks, especially if they don't like to drink water, what families can do. I know there's edible water out there and all sorts of different things.
Yeah, there's different things that can be done. It really depends on knowing what the patient likes. Popsicles are great. Heavy water foods like watermelon is great if the patient can take that. Giving water or juice or glass, non-caffeine, because caffeine actually causes you to lose more water. But giving it in a small glass as opposed to a very big glass psychologically seems more manageable. So having smaller glasses, frequent sips, things like that are important. Sometimes patients just need IV fluids.
And do you encourage diluting down juices since UTIs are very high as well?
So it depends. Sometimes we do if somebody is diabetic. But oftentimes the concern with dementia is patients will lose weight. And we know that weight loss in the face of dementia is a very important sign of advancement of their disease process. So for patients that I go to see in the memory care community, full fat ice cream, full fat butter, things like that, helping keep their weight up. So it depends. Sometimes you will dilute the juice if you're worried about too much sugar and things, but sometimes you'll just give the juice. Okay.
Have you tried the edible water with anybody?
I have not. So have we tried edible water? I have not. Have you had any experience?
I have. I actually did have someone we used to work with, and it worked well for a while, and then she didn't like the gummy feeling. I know they are now, it hasn't been approved officially by the FDA, but they are allowing them to ship it over here because it is from the UK.
Yeah.
So I've had other people trying it.
The UK is often a little bit more advanced than our FDA.
Yeah.
But yes, edible water, we are very excited about that. Patients with dementia, for multiple reasons, because the way that their brain interprets sensations, and sometimes their teeth, they have poor dentition. Patients with dementia can have very specific likes and dislikes with texture. So certain foods that they may have liked at one point, they may no longer want to take. So having the option for different things is very important. Yes.
No, it's just a general question for our situation. What if you have a patient who kind of really never been diagnosed correctly? I'm sure that happens in memory units. You just end up really just treating the symptoms, even if it could be delirium, it could be bipolar, it could be depression, it could be dementia, but sometimes it's just about treating whatever symptoms are present.
So the question is, how do we, when somebody does not have a formal diagnosis of dementia, but they're presenting with symptoms, do we just treat the symptoms? So if somebody is going into a memory care community specific for memory impairment, they have to have a formal diagnosis of dementia. But I work very closely with Adult Protective Services in Alexandria and Fairfax. We see this more often than not, where a person has dementia, they've just never been diagnosed. And you can tell, and it's not just one specific thing, it's a multitude of things. They're found wandering, they're not able to care for themselves. There's self-neglect with hygiene. So in cases like that, where the patient probably has moderate to advanced dementia, but they've never been diagnosed with dementia, the first thing to do is never assume. You have to check for other conditions that we had talked about. We have to do blood work, make sure they're not dehydrated, make sure that they don't have an infection. Because while they may have dementia, it may just be getting exacerbated by delirium caused by something else. So that does happen all the time, unfortunately, but it does involve continuity of care, having a good primary, having good specialists to follow and do the right sort of tests.
So When individuals are seeing changes in their loved ones and they're taking care of them, what is your advice to them? Is it better to call a doctor, use the medical portal, make an appointment? What's the best step, do you think, for them to get a soon enough response to see what could be done?
Sure, that's a good question. So it depends on the urgency. So, and I can speak from professional experience, from personal experience. If somebody is very agitated, say if somebody has minor memory issues, mild cognitive impairment, they know about it, their family knows about it, they occasionally forget their grandchildren's name, they know they no longer really drive, and that's okay, and they're doing fairly well. If they suddenly become very agitated, even if it's over a few days, if they're just sleeping more, if they're urinating, if they're not eating as much, these are things that are urgent. And while it may not be an emergency, there is an urgency. So getting in with your physician is important. Sometimes that can be piecemeal. Sometimes it's a visit that's scheduled 3 or 4 weeks out, but sometimes that means having a televisit a week out. Or if it's really urgent, bringing them to the emergency room where we can do a lot of testing and imaging and blood work and get the results back. And even if they don't get admitted, that's still very helpful for the primary care. But what I would say, bottom line, is if somebody has a question, they should always touch base with their medical provider, their triage nurse, their physician, their NP, their PA, and go from there.
So we had a question come up online. What criteria do you use to label a stage of dementia? Is there a standard system of stages of dementia?
So there are several stages of dementia. It's another talk that I actually do, but there's 7 stages of dementia. The easiest way that I remember is if we think about what we do when we are infants, when we are brand new babies. We are babies, babies they can't feed themselves. They can't change their diapers. They don't have bladder or bowel control. But eventually they start to have bowel and bladder control. Eventually they can hold the bottle and they can have that eye-hand coordination. Eventually they can sit up. Eventually they can stand. Eventually they can walk. Eventually they can converse. So if we think the stages that occur through infancy, there is a similarity for what we see in patients who are going through the stages of dementia. Now, it's not often that clear cut where you can say somebody's in stage 1, stage 2, stage 3, but oftentimes it can jump. Oftentimes you have a curveball thrown in there like a hospitalization or a delirium or an infection, but there are different stages. So we often refer to it as mild, moderate, severe. And then, of course, there's different stages, the 7 stages of dementia that we talk about. So there are different variations as well.
Thank you, Dr. Sinha. We truly appreciate you coming to Insight and sharing your perspective for our caregivers on the journey of dementia. Some upcoming events at Insight on April 19th and 26th. We have the Gen Silent movie screening and Q&A. May 10th, the Care Partner training on how to cover extended and long-term care costs. May 17th, the Alzheimer's Disease and Dementia Care Seminar. May 24th, a virtual dementia tour. May 31st, we're doing an online Caregiving at a Glance workshop. June 7th, we have an author spotlight welcoming LGBTQ residents with Tim Johnston. June 24th, Care Partner training, Driving in Dementia, and June 15th, the Care Partner training, Driving in Dementia out in Sterling. Please feel free to sign up for these or any of our support groups at insightmcc.org/events. And how can you help Insight? As we are a nonprofit, you can volunteer, donate monetary donations, wish list items, attend a class, sign up for our newsletter. If you'd like to talk to Insight further, please feel free to visit either of our locations, give us a call, visit us on our website, or send us an email. Thank you, and we'll see you next month.